Bismillahirrahmanirrahim. I am Dr. Mohsin Jamil, Senior Registrar from the Medical Unit 5 DHB Hospital, Faisalabad. Today we will discuss the different pericardial diseases like pericardial effusion, cardiac tamponade, pericarditis, and constrictive pericarditis. First of all, we will discuss the normal anatomy of the heart and the pericardium. As we all know, heart consists of the endocardium and the pericardium. The pericardium consists of the two layers, fibrous pericardium and serous pericardium. Outer layer is a fibrous and inner layer is a serous pericardium. The serous pericardium further got the two layers, visceral pericardium and the parietal pericardium. In between these two layers there is a small cavity or the space, it is called the pericardial cavity. Normally the small amount of the fluid up to the 50 ml it is present in this space or pericardial cavity. This is the same slide as we have discussed. The normal function of the pericardium is that it limits the extent of dilatation of the ventricles. It evenly distributes the pressure over the ventricles, resulting in the balancing of the right ventricle and left ventricle output. It decreases the friction and it is a mechanical barrier to the contiguous spread of the infection. It also provides the structural support while also having a substantial hemodynamic impact on the heart. This is the same slide as we have discussed about the parietal pericardium, serous pericardium and pericardial space or pericardial cavity. Now we will move towards the different diseases of the pericardium. An abnormal accumulation of the fluid in the pericardial cavity is called the pericardial effusion. Cardiac tamponade. Now the cardiac tamponade is an acute heart failure due to the compression of the heart by the large or rapidly developing effusion. It is a clinical syndrome caused by the accumulation of the fluid in the pericardial space, resulting in the reduced ventricular filling and subsequently hemodynamically compromised. The figure on the right side shows the normal anatomy of the heart and the pericardium, while on the left side it shows the accumulation of the fluid in the pericardial cavity, which results in the compression of the heart and the great vessels, which results in the cardiac tamponade and results in the hemodynamic compromise of the patient. There are two mechanisms for the pathophysiology of the pericardial effusion. The first one is an increased production of the fluid and the second one is a decreased absorption of the fluid. Any pathological process usually causes the inflammation with possibility of the increased production of the fluid. It results in the pericardial effusion. In this type of the effusion will be exudative. An alternative mechanism is the accumulation of the pericardial fluid may be by the decreased absorption due to the general increase in the systemic venous pressure as a result of the congestive heart failure or the pulmonary hypertension. In this type the pericardial effusion will be transudative. Pathophysiology is the same as we have discussed. The clinical manifestation are highly dependent on the rate of accumulation of the fluid in the pericardial sac. The pericardial effusion results in the increase in the pericardial pressure, which limits the ventricular filling pressure and ultimately result in the decreased stroke volume and reduced cardiac output. This table shows the different causes or etiology of the pericardial effusion. Broadly, we classify the pericardial effusion into the infectious group, iatrogenic, immune-mediated diseases or miscellaneous causes. Among the infections, tuberculosis is the most common cause of the pericardial effusion, while other bacterial, viral and fungal infections are also included in this. Iatrogenic causes include the cardiac surgery, radiation therapy, different drugs like minoxidil, penicillins, methylsergide, coronary perforation, right ventricular perforation. Different immune-mediated diseases like systemic lupus erythematosus, rheumatoid arthritis, scleroderma, Dressler syndrome and idiopathic causes, while the miscellaneous causes include the malignancy, hypothyroidism, uremia, heart failure, renal failure, pericardial infarction and hemorrhagic pericardial effusion in the case of the aortic dissection and trauma of the free wall rupture. Now we will move towards the classification of the pericardial effusion. We can classify the pericardial effusion on the different parameters like onset, size, distribution and composition. On the basis of the onset, we can classify it acute, subacute and chronic. On the basis of the size, it is mild, moderate and large. If the pericardial fluid is less than 10 mm, it is mild. It is 10 to 20 mm, it is moderate, and greater than 20 mm, it is large. On the basis of the distribution, we can classify a pericardial effusion into circumflexial and lobulated. On the composition, as we have discussed in the previous slides, it can be classified as a transudative or exudative. The clinical presentation of the patient with the pericardial effusion will vary according to the underlying process, rate of accumulation and hemodynamic effect. The characteristic feature of the pericardial effusion is a chest pain, pressure or the discomfort. The chest pain is characteristically it is a retrosternal pain which is relieved by the sitting and leaning forward and is intensified by the lying position. The other clinical features include the lightheadedness, syncope, palpitation, cough, dyspnea, hoarseness, anxiety and confusion and hiccup. The rules of the physical examination in the patient with the pericardial effusion are first to assess the hemodynamic consequences of the pericardial effusion and second to identify the signs of suggestive of underlying cause. During physical examination, we can have tachycardia, tachypnea and decreased breath sound. One sign in the pericardial effusion is called the award sign. It is dullness to the percussion beneath the angle of the left scapula from the compression of the left lung by the pericardial fluid. The classical triad during the physical examination of the pericardial effusion or pericardial tamponade is hypotension, muffled heart sound and increased jugular venous pressure as evident by the jugular venous distension. This classical triad is called as Beck triad. Other physical signs which may be detected is pericardial friction rub, hepatojugular reflux, hepatosplenomegaly may be appreciated, and weakened peripheral pulses, edema and cyanosis. Pulses paradoxis is an important sign during the physical examination of the pericardial effusion or pericardial tamponade. It is an exaggeration of the normal physiological phenomena. Normally, the systolic blood pressure falls during the inspiration. If the systolic blood pressure decreases more than 10 mm of Hg during the inspiration, it is called as pulses paradoxis. Next is the cardiac tamponade. The pericardium can stretch over the time, but at any instant it is inextensible, making the heart compete with the increased pericardial content for a fixed intrapericardial volume. The key element are the rate of the fluid accumulation relative to the pericardial stretch and effectiveness of the compensatory mechanism. If the pericardial effusion develops in the sudden onset, then the compensatory mechanism will be less effective and patient will be more symptomatic. While if the pericardial effusion will develop over a prolonged period of the time, the compensatory mechanism will be more effective and patient will be less dramatic. This table shows the rate of the accumulation of the fluid to the effectiveness of the compensatory mechanism. As we have discussed, if the pericardial effusion will be of sudden onset, then the signs and symptoms will be more life-threatening, like chest pain and dyspnea, and JVP will be more marked, and there will be more marked hypotension and narrowing of the pulse pressure and decrease in the cardiac output. Heart sound will be muffled and effusion will be relatively small. If the effusion develops over a prolonged time period as evident by the subacute onset, then it will be less traumatic process. Patient may have asymptomatic or may have less signs and symptoms like dyspnea, chest comfort and fullness. Peripheral edema will be more evident in the chronic tamponade, and hypertension may or may not be present, and pre-existing hypertension may remain hypertensive due to the increased sympathetic activity. In the investigation of the pericardial effusion, we will offer the two sets of the investigation. First set is a baseline investigation and to confirm the pericardial effusion. and the second set is to identify the cause of the pericardial effusion. The baseline investigation include the CBC, ESR, CRP, electrolytes and cardiac enzymes, and then we will move towards the chest radiography. The chest radiograph shows the enlarged cardiac shadow. Water bottle heart can be seen in the case of the pericardial effusion. After the baseline investigation, we will move towards the specific investigation like pericardiocenetesis. Pericardiocenetesis can be diagnostic as well as therapeutic, and we can perform the fluid analysis of the pericardial effusion, complete examination, culture sensitivity, adenosine deaminase level in the case of the tuberculosis, and in the case of the malignancies we can perform the carcinoembryonic antigen. Other investigations we can offer the CT scan and MRI to detect the pericardial effusion. To determine the underlying cause of the pericardial effusion, we can perform the thyroid profile, RA factor, immunoglobulin complexes and ANA level to rule out any immune mediated disease. In pericardial fluid analysis, we can perform the different parameters to determine the underlying cause of the pericardial effusion. We can check the specific gravity, protein level, protein fluid to serum ratio, LDH level, glucose level, and red blood cell count to differentiate from the exudative and transudative pericardial effusion. If the protein will be greater than 3 gram per deciliter and ratio of the protein fluid and serum will be greater than 0.5, it will be the exudative. In the case of the malignancies, we can perform the cytology and different tumor markers like carcinoembryonic antigen. In the case of the tuberculosis, adenosine deaminase level, ADA level greater than 40 units per liter will be identified. And we can also perform the PCR for the infectious agent like tuberculosis. In the case of the other bacteria, we can perform the aerobic and anaerobic cultures of the pericardial fluid to determine the cause of the pericardial effusion. This is a typical chest X-ray of the pericardial effusion showing the enlarged cardiac shallow water bottle heart. This is another X-ray showing the globular or enlarged water bottle configuration in the chest X-ray PA view showing the pericardial effusion. In the ECG, there is a specific pattern called the electrical alternance. It is a beat to beat variation in the direction and amplitude of the QRS complex. It is due to the swinging of the heart in the pericardial fluid. Another specific pattern which can be observed during the pericardial effusion is the low voltage complexes in large effusions and tamponade. This is the ECG of the electrical alternance. As we can see, the one complex is a large which is preceded by the small complex. It is called electrical alternance. This is a typical ECG in the case of the pericardial effusion. As we can see, the small low voltage QRS complexes and electrical alternance. One complex is a large and the other complex is a small in amplitude and size. Next investigation is echocardiography. The pericardial effusion appears an echo-free space between the visceral and the parietal pericardium. The other signs of the tamponade can be identified by the echocardiography. These are the swinging of a heart, early diastolic collapse of the right ventricle, late diastolic collapse of the right atrium, abnormal ventricular septal motion, and respiratory variation in the ventricular chamber size, aortic outflow velocity. Echocardiographic pulses, paradoxes, and inferior vena cava plethora can also be observed during the echocardiography. Next is a CT scan and MRI. CT scan and magnetic resonance imaging MRI may be superior to the echocardiography in detecting the loculated pericardial effusion, especially when these are located anteriorly. Now we will move towards the management. The management include the hemodynamic support, hemodynamic monitoring with the balloon floating pulmonary artery catheter, IV fluid resuscitation if necessary, and IV positive inotropes like dobutamine and dopamine can be used but are of limited use and should not be allowed to substitute for the delay of the pericardiocentesis. Positive pressure ventilation should be avoided. Other pharmacotherapy includes the NSAIDs like indomethacin, ibuprofen, diclofenac or aspirin to relieve the pain, corticosteroids like prednisolone and methylprednisolone, and other anti-inflammatory agents like colchicine can be offered. In the case of the bacterial, we can offer the different antibiotics according to the situation. In the case of the tuberculous pericardial effusion, we will offer the ATT. In the anti-neoplastic therapy like systemic chemotherapy and radiation according to the cause of the pericardial effusion. In the case of the recurrent pericardial effusion, we can offer the sclerosing agent like tetracycline, doxycycline, cisplatin and 5-fluorouracil. Pericardiocenetesis, it is used for the diagnostic as well as the therapeutic purposes. Percutaneous pericardial fluid drainage is the most common method used for the pericardial fluid removal. It can be performed under the fluoroscope, echocardiograph or CT guided. This slide shows the different approaches for the removal of the pericardial fluid. These are the subxiphoid, parasternal or apical approach to remove the fluid from the pericardial space in order to relieve the pressure on the heart and the great vessels and to relieve the cardiac tamponade. In the case of the recurrent cardiac tamponade, as we have discussed, we can offer the sclerosing the pericardium with tetracycline, doxycycline, cisplatin and 5-fluorouracil. Other options include the pericardio-peritoneal shunting and pericardectomy. The prognosis in the idiopathic pericardial effusion and pericardial centesis have an overall good prognosis with the low risk of the complication, especially in the effusion with the mild to moderate. In large idiopathic chronic effusions greater than 3 months have a 30 to 35 risk of the progression to the cardiac tamponade. Now we will discuss the next topic, acute pericarditis, the most common pathological process involving the pericardium. It is classified according to the clinical as well as the etiological agent. The clinical presentation, the clinical classification includes the acute, subacute or chronic pericarditis. It is according to the duration. If the duration is less than 6 weeks, it is called acute pericarditis. It may be fibrinous or effusive. In the case of the subacute, the duration is between 6 weeks to 6 months. In the case of the chronic pericarditis, the duration is greater than 6 months. This slide shows the different etiological factors causing the acute pericarditis. These are the trauma, tumor, uremia, myocardial infarction, medications and other infections like viral, bacterial and fungal, TB, other autoimmune diseases like rheumatoid, autoimmune disorders and radiations. The clinical features include the fever, malaise, myalgia. The most common characteristic feature of the pain is the retrosternal which radiates towards the trapezius on the back. It can also radiate towards the left shoulder or arm. The special characteristic of the pericardial pain, it is more likely to be sharp with coughing and inspiration and swallowing, and worse on the lying position and relieved by the sitting or leaning forward. This table shows the comparison or the differences in the acute pericarditis and myocardial infarction. The pain of the pericarditis is sharp, pleuritic, retrosternal pain, and this pain radiates towards the trapezius to the lower portion of the scapula on the back, or it may have no radiation. While in the case of the myocardial infarction, the pain is crushing like a pressure or a heavy pain, and it radiates towards the jaw or left arm. Or the pain of the pericarditis does not change on exertion, while the pain of the myocardial infarction, it can increase on exertion. The pain of the pericarditis, it is worse on the supine position, while there is no postural differences in the case of the acute myocardial infarction. This table shows the ECG differences in the case of the acute pericarditis and acute myocardial infarction. As in both of these cases, there is ST segment elevation. But in the case of the acute pericarditis, there is upward concavity of the ST segment elevation, and the PR segment will be depression. And in the case of the acute myocardial infarction, there will be the upward convexity of the ST segment, and there will be the reciprocal depression in the reciprocal leads. This ECG shows a typical ECG of the acute pericarditis with the diffuse ST segment elevation. These ST segment elevation are typically concave upward. The management of the acute pericarditis include treat the underlying cause, and in order to relieve the symptoms, we need the analgesic agent like codeine, anti-inflammatory agent like aspirin, NSAIDs. Corticosteroids are symptomatically effective but preferably avoided. Now we will move towards another important pericardial disease is chronic constrictive pericarditis. This disorder results when the healing of an acute fibrinous or pseudofibrinous pericarditis or resorption of the chronic pericardial effusion is followed by the obliteration of the pericardial cavity with formation of the granulation tissue. These are the causes of the chronic constrictive pericarditis. These causes are almost same as we have discussed in the pericardial effusion. Infectious disease, infectious causes, trauma, cardiac surgery, inflammatory diseases, neoplastic radiation, end-stage renal diseases, and idiopathic causes. The clinical presentation, the usual presentation consists of signs and symptoms of the right-sided heart failure. These include the lower extremity edema, vague abdominal complaints, and passive hepatic congestion. Later on, the hepatic congestion worsens and can progress to the ascites and generalized anasarca and jaundice due to the cardiac cirrhosis. The elevated pulmonary venous pressure leading to the exertional dyspnea, cough, and orthopnea may also appear with the progressive disease. The other features include the atrial fibrillation and tricuspid regurgitation. In end-stage constrictive pericarditis, the effect of the chronically low cardiac output are prominent, including the severe fatigue, muscle wasting, and cachexia. The other findings include the recurrent pleural effusion and syncope. These signs and symptoms can be mistaken for any cause of the right-sided heart failure as well as end-stage primary hepatic disease. An important sign during the physical examination of the constrictive pericarditis is the Cosmol sign. Markedly elevated JVP with a prominent rapidly collapsing wide descent. Normally what happens during the inspiration, there is the negative intrathoracic pressure and the venous pressure falls during the inspiration. Venous pressure may fail to decline during the inspiration. It is called as Cosmol sign. Other signs which may be observed during the physical examination of the constrictive pericarditis, these are the pericardial knock in the 50% of the cases, wide subplating of the second heart sound, as the gallop may be present, and secondary tricuspid regurgitation. Hepatomegaly often with palpable venous pulsation, ascites, and lower extremity edema. Now we will move towards the investigation. Investigation includes ECG. In ECG, there will be the low voltage of the QRS complexes, diffuse flattening or inversion of the T wave, and atrial fibrillation may be present in about 1/3 of the patients. In chest X-ray, the chest X-ray shows a normal or slightly enlarged heart, and there is a pericardial calcification as pointed out by the arrow, and most common cause in the tuberculous pericarditis. After the X-ray, we can offer the echocardiogram. The pericardial thickening, dilatation of the inferior vena cava and hepatic veins, and arterial enlargement can be seen on the echocardiography. The next investigation is a CT scan. In the CT scan, we can identify the thickened pericardium as pointed out by the arrow in the diagram. The differential diagnosis of the constrictive pericarditis include the cor pulmonale, tricuspid stenosis, and restrictive cardiomyopathy. In the treatment of the constrictive pericarditis, pericardial dissection is the only definitive treatment of the constrictive pericarditis. The dietary sodium restriction and diuretics are useful during the preoperative preparation. Coronary arteriography should be carried out preoperatively in patient older than the 50 years of the age to exclude the unsuspected coronary disease. In the case of the tuberculous constrictive pericarditis, which is the most common cause of the constrictive pericarditis, pericardectomy should be performed as early as radically as possible. The anti-tuberculous therapy may be administered, it should be administered for the minimum of the 9 months in patient in whom the pericardial effusion is present. 3 months of the corticosteroid therapy may be useful as an adjunct. Thank you. It's all about the today topic.